Next, we'll move on to the various malabsorption syndromes. So, there are various diseases which can lead to malabsorption. Let us see the very few only. So, we'll see about Whipple's disease, celiac sprue, and tropical sprue. So, clinically, how will the patients present with? Since there is going to be malabsorption of various vitamins, minerals, and also certain vitamins, so it is going to cause symptoms based on the deficiency. So, osteopenia will be there due to vitamin D and calcium. So, vitamin D and calcium deficiency, it is going to lead to osteopenia. So, the patient can also present with bleeding as a result of vitamin K deficiency, anemia as a result of iron absorption, vitamin B12 absorption, or even folic acid absorption. So, all of this can lead to anemia. Then you can also even copper and zinc. Okay, and glossitis and cheilitis again related to anemia. Then steatorrhea, so due to fat. So steatorrhea is nothing but the presence of fat in stools. The stools are going to be bulky and foul smelling. So steatorrhea is actually the hallmark of malabsorption. So if they see this kind of bulky foul smelling stools along with multiple deficiency in the patient, they'll have to suspect a malabsorption. So let's see what are the malabsorption syndromes, starting with Whipple's disease. So Whipple's disease is actually an infective disease caused by a actinomycete called as Trophorema whipplei. Trophorema whipplei, it is an actinomycete which is gram positive and it will lead to malabsorption. So it doesn't just affect the GIT, it can also affect the lymph nodes, lymphatics, and then brain and joints as well. So intestine, apart from intestine, the entire GIT can be involved. Brain, lymph nodes, lymphatics, and joints can also be involved by the Whipple's disease. So this image was asked, I think, in the previous year, somewhere this year or no, previous years, I think. So this image based question was asked. So Whipple's disease, it's going to present with lots of collections of foamy macrophages in the lamina propria. So this is the epithelial layer, and beneath this part is the lamina propria. So if you see in this lamina propria, it is filled up with these foamy macrophages. So back to back, it is filled up with these foamy macrophages, and these foamy macrophages have actually taken up this Whipplei, Trophorema whipplei actinomycete. So it is filled up with this organism, and it is going to be PAS positive, which is periodic acid shift positive, and it is diastase resistant. So only thing which will be diastase sensitive was glycogen, right? So here it is going to be diastase resistant, and the most important differential diagnosis for Whipple's disease will be tuberculosis. In tuberculosis also, you can see collection of macrophages. Again, the macrophages will be filled up with the tuberculous bacillus. But how will you prove that? There again, it can be PAS positive, but if you put a acid fast stain, the tuberculous will be positive, that is Zeal-Nielsen stain. So AFB will be positive in TB, while AFB will be negative in Whipple's disease. Okay. So the second disease of malabsorption will be celiac disease. So celiac disease is also called as gluten sensitive enteropathy, because these patients are quite sensitive to gluten. Gluten is a substance present in some of the foods which are basically called as bro foods. In short form, they call it as bro foods. So bro stands for barley, rye, oats, and wheat. So when food contains this bro, so it is going to lead to some kind of malabsorption in certain genetically susceptible individuals. So not all patients. So only those patients who have a HLA-DQ or DQ2 or DQ8. Okay, so these patients are quite susceptible for developing gluten sensitive enteropathy when they consume gluten foods. So remember this HLA-DQ2 and DQ8 is again was asked in MCQ. So it is a type 4 kind of hypersensitivity against the gliadin which is present in the gluten. So gliadin is present in the gluten, and this is going to cause a type 4 hypersensitivity, which is a delayed type of hypersensitivity. So what actually happens is that this gluten, which is it is going to be degraded by some of the protease enzymes caused by the pancreatic and the intestinal enzymes. So some of this gluten are not going to be degraded. They are resistant to degradation. So they will break down into this gliadin parts. So this gliadin is resistant to degradation, and this gliadin, it will actually enter through the enterocyte. So it is going to traverse through the enterocyte and enter into the lamina propria. So there it is going to trigger the interleukin 15 expression on the enterocytes. So this gliadin will trigger the interleukin expression on the enterocytes, and this interleukin 15 is going to recruit intraepithelial lymphocytes. So which are going to be CD8 positive T cells. Okay. So CD8 positive T cells are actually cytotoxic T cells. So these CD8 positive T cells which are being recruited will actually cause the death of this enterocytes. So they will cause the killing of the enterocytes, and that will lead to apoptosis of the enterocytes. So it is going to loss. So when these enterocytes are again being lost, so lots of enterocytes are being lost, so gliadin can again enter. So lots of gliadin can enter through the enterocyte through the defect caused now. So lots of enterocytes, lots of gliadin again enters, and when this gliadin enters into the lamina propria again, now there is going to be transglutaminase enzyme which is going to be activated. So transglutaminase we represented by TG. So transglutaminase is going to act on this gliadin particles, and then there will be this gliadin particles will be presented to the antigen presenting cells. So antigen presenting cells will take up these gliadin particles and present it to the CD4 positive T cells. So CD4 positive T cells will then again recruit the B cells. So B cell, it will be activated based on the T cells. B cells will be activated, which will differentiate into plasma cells. These plasma cells will produce antibodies against this gliadin and also transglutaminase, and also against anti-endomycin. So there will be 3 antibodies produced, which are anti-transglutaminase, anti-gliadin antibodies, and anti-endomycin antibodies. These 3 antibodies are being produced. So these again are going to damage the enterocytes. So all of this will actually trigger in the enterocyte apoptosis. So remember this thing, the main thing which had actually happened is it was a CD4 mediated, it is a type 4 hypersensitivity reaction. So it is going to be, the main cell will be the CD8 T cells which is going to cause the enterocyte apoptosis as a result of interleukin 15 expression. Okay. Other than that, we are also having this antibody formation. Okay. So in this antibodies, this anti-transglutaminase is going to be a very sensitive, most sensitive antibody will be the anti-transglutaminase, while anti-endomycin antibody will be the most specific antibody. Okay. So other than that, this celiac disease is going to be associated with other autoimmune diseases like diabetes, Hashimoto's thyroiditis, etc. Also, it is going to be associated with a special disease called as dermatitis herpetiformis. It is a skin condition actually. So here in dermatitis hepatitis, you will have neutrophilic microabscesses formation at the tip of the papillae. So this is also in skin, they'll be discussing this. So it is a very important MCQ there also. Neutrophilic microabscesses present at the tip of papillae, and it is going to be IgA related. Okay. So when you stain with IgA, you can see these neutrophilic microabscesses on immunofluorescence. So it is an IgA related disease. So when we read about IgA nephropathy in kidney also, I must have told that it was related with celiac disease. Remember? So all of this can occur together. IgA nephropathy, celiac disease, dermatitis herpetiformis. All of this can occur together. And what is very much important about this celiac disease is that it is going to have an increased risk of developing adenocarcinomas. Other than that, a lymphoma also, because lymphocytes are being activated chronically here, right? So enterocyte associated T cell lymphoma. EATL is enterocyte associated T cell lymphoma. So both risk for EATL and adenocarcinoma is there associated with celiac disease. So on microscopy, a very important feature is here. So suppose this is the normal villus. Okay. So this is the normal villus architecture of the small intestine. So what happens in celiac disease is that there is going to be villus atrophy because of this CD8 mediated T cell killing. So there is going to be enterocyte apoptosis, right? So that will lead to the atrophy of the villus. So rather than being tall like this, they are all blunted here, right? So it is all blunted over here. So this is the villus atrophy. But there is going to be regenerative hyperplastic crypts. So this crypt hyperplasia will be there. So lots of crypt hyperplasia will be there. So even though the villus is going to be atrophied, the crypt hyperplasia will be there. So this is going to match up, and the mucosal thickness will be the normal. So this is very important. Mucosal thickness is normal in celiac disease, even though there is villus atrophy, because there is going to be compensatory crypt hyperplasia in this. So the most important T cell here was CD8 T cells. Okay. And moving on to the next malabsorption syndrome, which is tropical sprue. So tropical sprue is going to be an environmental enteropathy associated with E. coli infection. So in E. coli infection, it can involve all the parts of small intestine, starting from duodenum, jejunum, and ileum. So when there is going to be malabsorption, since iron is going to be absorbed in the duodenum, when this is not there, so it is going to cause iron deficiency anemia. And in jejunum, we know folic acid is being absorbed. So, and ileum, it is B12 is being absorbed. So, when B12 and folic acid is not being absorbed properly, it will lead to deficiency, causing megaloblastic anemia. So, both iron deficiency and megaloblastic anemia can also be seen here. So, since it's an infective condition, we can treat this condition with antibiotics, and as such, there is no increased risk of cancer here.